Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. My name's Jim Scott and I'm the President and CEO of Applied Policy. My colleagues and I host these gatherings to share information and exchange ideas with you on important health policy issues. As you know, there's a lot going on in Washington's health policy world. Policymakers are grappling with ongoing challenges such as lowering prescription drug costs, changing the minds and behaviors of vaccine-resistant populations, and as the pandemic mitigates, returning to confront pre-existing conditions of obesity, heart disease, and diabetes faced by everyday Americans, providing better care for people with Alzheimer's, and launching a cancer moonshot. So today I'm joined by reporters Michelle Stein and Maya Goldman, who have a front row seat to these debates in Washington, D.C. Michelle Stein is chief editor for Inside CMS, Inside Health Reform, and Inside Health Policy. She has covered Medicare and Medicaid policies, as well as healthcare legislation and healthcare reform for more than a decade. Most recently, she has written about nursing home reform and congressional efforts to lower drug prices. We're also joined by Maya Goldman, who writes about health rules and regulations for modern healthcare, reporting from Washington, D.C. She previously covered Medicare and Medicaid for Inside Health Policy and reported on education for the Wall Street Journal. Thank you, Michelle and Maya, for joining us today. To the audience, if you have a question you would like to ask one of the panelists, please put it in the chat and I'll try to work it into the presentation. But with that, let's kick it off. So, Michelle, maybe you could tell us a little bit more about Inside Health Policy and its readership and what's unique about it, and then we'll turn it over to Maya to tell us what's different about modern healthcare and its readership.
So Inside Health Policy has actually, that's our overarching website and the overarching newsletter for a couple different publications. We have, I think, 5 now. We have Inside CMS, which is the one I have worked for about a decade, covering Medicare and Medicaid. We have FDA Week. We have Inside Drug Pricing. We have Health Exchange Alert, and our news publication is Inside Telehealth. And as Jim mentioned, I serve as the chief editor for Inside CMS, and I'm also the assistant publisher for all of Inside Health Policy. So I wear a couple different hats, along with being a reporter. And Inside Health Policy is kind of unique in that we like to say that we kind of get into a lot of the details. That's kind of where we live, is in the details and in the weeds of all of the policy, and trying to find out as much about all of these different details and how everything is going to work when it gets implemented as we can. So we like to say that a good part of our job basically starts after a law or something like that gets passed, and once it gets implemented, that's where we really kick in following. And where we really 90% of our work is after you've got a lot of it following how something gets passed, and then a good chunk of work following how it's actually going to get implemented. As everyone says, the devil's in the details. So I think that's pretty much what makes Inside Health Policy unique and what makes Inside Health Policy special. Our readers are a lot of those on Capitol Hill, and a lot of people like you who are interested in all of those details and are looking to find that kind of behind the scenes inside scoop on the nitty gritty of how this is all going to work out.
Thanks, Michelle. So Maya, can you tell us a little bit about modern healthcare and its goals and audience and what makes it unique?
Yeah, absolutely. So I actually started covering health policy at Inside Health Policy with Michelle, and she taught me most of what I know. So great place to learn the ins and outs of policy. And now I'm at Modern Healthcare, where I cover pretty much anything that comes out of HHS with a provider-focused lens. So Modern Healthcare is not exactly a trade publication, but along the lines of a trade publication for providers, and primarily those who work in the hospital setting. And so I consider my job to be taking all those details and reading them myself, from the policies, and then making them understandable to providers and people who actually need to understand them for, to do their own jobs. So that's sort of where I think modern healthcare lies.
Thanks, Maya. And let's stick with you. What trends have we seen in Medicare payment rules so far this year? I think there was one last night.
There was, yeah. If you are on this call, you probably know that a lot of Medicare payment rules come out in April. So it has been a big month for me and for probably Michelle as well, I would imagine. And so we've seen payment rules. Last night, the hospital payment rule came out. Last week, we saw one for skilled nursing facilities, rehab, inpatient rehabilitation facilities, and inpatient psych facilities and hospices, I think are the ones that we've seen so far, and definitely noticed some trends. Last year was kind of all about CMS in the first year of the Biden administration saying that they were collecting information about health equity and how to incorporate that into the pay rules. And we've started to see some actual action on that. Last night in the hospital inpatient proposed rule, they proposed some new quality reporting measures related to health equity, but it's still a lot of information gathering and not a ton of operationalizing that stuff yet. So that's interesting to me. We're seeing a lot of COVID-19 policies still factoring in, like suppressed quality measures, different changes in in reporting and things like that related to the pandemic. But we're also starting to see CMS roll back on some of those things, which is a broader change that I'm sure we'll talk about later in their policy. Certain years of data that they're deciding to use and just discounting certain factors of it. So that's something that's caught my eye as well. And then there have been some other sort of wonkier things that they've done, like capping annual decreases on wage indices. And so that's something they've done across all payment rules so far to sort of stabilize payment. And I'm really curious to see how that makes a difference and what becomes of that.
Great, thanks, Maya. Hey, Michelle, any trends that you're spotting in the fiscal year rules that are being proposed this month?
Well, one thing I will say that jumped out at me yesterday with the hospital inpatient rule is the changes to conditions of participation for the hospitals regarding reporting after the pandemic. So we're starting to get, it's this odd mix of, we still have COVID-19 policies. For example, a lot of the, what you call the quality programs, we're seeing things suppressed in CMS say, well, we're not going to penalize people for these quality programs. For the readmission, I believe it was the value-based purchasing program and the readmissions, hospital acquired conditions readmissions program. But so we're not going to penalize people for this. But at the same time, they're also trying to plan out a little bit further now for after the pandemic. And because the reporting of COVID-19 cases that had been, I'm sure you all remember, a little bit sticky for a little while, let's say, and a little messy, they put in place a policy that says they are going to change conditions of participation to have the hospitals report on COVID-19 and seasonal influenza cases after the public health emergency ends. And they also added something in there that basically says other respiratory diseases and other disease pathogens that could be considered epidemic or pandemic are also going to have to be reported moving forward if HHS says that they basically want the information, and set it up so that these things will have to be reported to, I believe, CDC, although I will double check myself on that. So that was really interesting yesterday, this combination of, yes, we're still dealing with some of these COVID policies, but at the same time, you see this different look where they're trying to set things up for going forward a little bit. And you kind of are getting a lot of balance with this across not only the payrolls, but the payrolls as well as some of the other policies that are coming out. For example, you had some similar policies with the nursing home, with the SNF pay rule, where certain things, are going to be, there's going to be some less penalties, et cetera. But you also see some of the COVID-19 waivers for nursing homes being pulled back separately, even though the public health emergency hasn't ended, with CMS saying that we think that the landscape has changed enough that we can start changing and rolling back some of these COVID-19 waivers, particularly with regard to in-person visits and training for nursing home staff. So that's kind of interesting. We're kind of in this dual focus area right now.
So,
Yeah.
so do you see these as signs that the extension of the COVID public health emergency to mid-July is the last extension, and we should start expecting it to expire, or do you think they'll extend it one or two more times after that?
So what I've learned with this public health emergency is not to try and predict anything too far out, because every time we try and predict something too far out, then a new variant pops up or the landscape changes. Things have shifted whenever anyone tries to predict. But I will say that for some time, there has been an expectation that July would be kind of the end date for the public health emergency, if for no other reason than that is what the Congressional Budget Office quite a while ago had projected as the end date for the public health emergency. Now, that said, I know there are some groups there are some groups that have been pushing to continue the public health emergency beyond that, in particular, so that the Medicaid eligibility redetermination process doesn't kickstart, and from a political standpoint, kickstart in the middle of the run up to the midterms, where a bunch of people start losing their Medicaid coverage in the run up to an election. So that has also been kind of a complicating factor that some people have brought up. So it's kind of something to watch.
Yeah, I would agree with Michelle. It's hard and kind of silly to try to predict these things in advance, but there is also a lot of political pressure in Congress from Republicans to end the designation. And now that I think this newest BA2 wave, I've read some pieces that say this is kind of going to be a turning point. If this wave results in a lot of hospitalizations, we might see an extension, whereas if this is sort of a more muted strain, and that seems indicative of what we'll see in the future, this could be the end.
I think we'll know 60 days from July, right? Because there has been that promise from Secretary Becerra on multiple times that 60 days will be the notice. And Secretary Becerra has said that we can't really give more than 60 days notice, because every 90 days we have to start this whole process of reviewing things. So that's about as much time as we can give you, because there have been pushes for 120 days notice or 90 days, longer timeframes. And Secretary Becerra has basically said it's not workable.
So everybody mark your calendars, May 17th. It'll either be extended or ended. So also, I noticed in the inpatient rule that there was CMS proposed C-section, obstetric complication, and other hospital measures. I think we all know Medicare's in general for the program for senior citizens. And then it also covers disabled populations that are younger. So do you see this as a policy that's targeted at better serving the people with disabilities who have Medicare, or is it more of a policy lever to influence maternal health care broadly, using Medicare as a tool to improve maternal care for everyone? Maya?
Yeah, I'm interested to hear what Michelle thinks about this, actually, but I see this as a policy lever. Medicare is sort of where hospital quality reporting at a large scale lives. And so this is an easy place to include something like that. And so that is not so crazy to me, but I think, it is something to look at and pause and sort of say, Medicare is not really paying for many births. So that's curious.
So,
What do you think, Michelle?
so Medicare is not paying for many births, but Medicaid is. Medicaid it pays for a large percentage. And if you look at part of the fact sheet yesterday, and I'm going to be honest, the only way I know this is I happen to have one of Inside Health Policy's latest stories on the maternal health part from yesterday pulled up. The CMS had said that it's specifically exploring how to address the maternal health crisis through existing policy and program requirements, including but not limited to the conditions of participation and through measures in CMS quality programs. That to me indicates this is a lever. With the maternal health week, the 5th annual Black Maternal Health Week, HHS and the White House, the administration overall, has done quite a few events and roundtables and pushes on maternal health. And I think this goes a little bit back to that push for equity that the White House has been undergoing as well. But they have been trying to make a show that we are looking at this issue. We are aware of this issue. We are trying to find levers to improve some of this. The other thing with conditions of participation is conditions of participation can be for Medicare and Medicaid. They aren't always limited to one or the other program. And so sometimes the IPPS is just a convenient regulatory tool for updating something like that.
Yeah, and they've, sorry, I was just going to say CMS has made an effort in Medicaid as well, an explicit effort in Medicaid to improve some maternal health coverage with really trying to push this expanded postpartum coverage of Medicaid state plan option, and we've seen a lot of press around that this month. So they're definitely using that lever as well.
Sorry, Maya, I didn't mean to cut you off there, but it's interesting in and of itself because at the same time you have the Tri-Caucus from the House sending letters to the White House saying, well, this state plan amendment is good, that option is positive, but this 12 months of postpartum coverage should be required, not an option. It should be necessary. I apologize ahead of time for my dog deciding to bark at the construction workers across the street. I will do my best to keep her from doing that.
No worries. Maya, so more and more seniors are electing to get their healthcare through Medicare Advantage as opposed to the traditional fee-for-service Medicare program. What trends are you seeing in Medicare Advantage?
Yeah, this is a space that I have really been watching because it is growing so rapidly, and CMS is paying, Medicare is reimbursing more Medicare Advantage insurers more per beneficiary than it would for the same fee-for-service beneficiaries. And so, it's very popular. It's not so great for Medicare's financial stability, but it does seem to be, working for a lot of seniors, and it's a space that's ripe for innovation. A lot of that extra reimbursement is going towards supplemental benefits that beneficiaries can't necessarily get in fee-for-service Medicare. And so I'm curious to see what will happen either from Congress or from CMS in regards to how to sort of equalize that reimbursement playing field. I don't think that we're going to see anything anytime soon because Medicare Advantage has a lot of bipartisan support in Congress, and CMS could have raised the coding pattern adjustment in the most recent Medicare Advantage rate notice, and they chose not to do that, although they did say that they're taking comments asking them to do that into account for the future. But CMS, their party line, HHS's party line has kind of been, we know this is a problem, but we need Congress's help. And then, of course, there are advocates that are saying, you can do stuff on your own. Why aren't you doing that? So I think we're kind of in a holding pattern, and Medicare Advantage is just going to continue to grow. And So I'm really curious to see what's going to happen with that.
Thanks, Maya. Michelle, Medicare Advantage plans got almost an 8% raise this year. And then I'm looking at the headline for hospitals, and under the fee for service program got a 3.2% increase. Any thoughts on why so much bigger for Medicare Advantage than for our hospitals?
That is a big question that providers are asking as well. And it's not just the hospitals either. When the almost 8%, the 8% raise came out for Medicare Advantage plans, the doctors immediately, led by, I believe, the American Medical Association, were upset and writing to Congress saying, we're facing a pay freeze under a potential pay freeze under the physician fee schedule. Of course, that rule is not out yet. We're all going to be watching for that as these fiscal year pay rules are now all released. So we start looking for the proposed calendar year pay rules, including the physician fee schedule. But after MedPAC had suggested, hey, keep the physician pay freeze, the physicians were saying, hey, how on earth is this okay to give the plans an 8% pay raise while physicians are seeing something that is supposed to be a pay freeze? The hospitals are getting, and it's not just 3.2%, which is what CMS had projected, but when hospitals initially reacted to the rule last night, the reaction was, this is nowhere near enough for us. And on top of that, you have this reduction in Medicare disproportionate share hospital payments, which could leave us basically keeping up with inflation. So I think it's a big question why the plans are seeing these increases while the providers say that they're not. And there's some thought that, the providers have gotten some extra boon during the pandemic with the provider relief funds and some other forms of supplemental help, like, for example, the moratorium on sequestration. And so now it's time to basically do more of a shift back towards a playing field that doesn't give them as many extras. However, a lot of the providers are saying that we're not out of the pandemic. And so we're not to a point where we're ready for that yet. And it's kind of raised a whole lot of questions as to why this 8% increase was put into place. Also, especially if you compare it to past years, 8% is large compared to the increases we've seen in the past. So I think it's just a big open question.
Yeah, and an important thing to remember about the rate notice, Medicare Advantage rate notice, is that 8% includes, like, I think a 3.5%. Can't remember exactly what it's for, but it's a figure that hasn't been in these rate notices included in the overall percentage increase before. And so the actual number to look at is the growth rate, but that's still way higher than what these provider settings are receiving, and way higher than it has been in the past for Medicare Advantage plans. So I think Michelle is totally spot on there.
So another hot button item has been mental health care, and over recent years, a lot's been done to improve access and remove stigma from mental health care. Can you tell us a little bit about what you've seen lately, this administration doing on mental health care issues? Go ahead, Maya.
Yeah. There has been a big focus on mental health care from the Biden administration. Biden has sort of identified mental health care as part of his consensus agenda, which means that he thinks it's something Republicans and Democrats can both agree on. Remains to be seen. I'll believe it when I see it. But the fiscal year 2023 budget released by the Biden administration has a lot of mental health care provisions, especially having to do with increasing the number of providers and expanding access to care, and more grants to programs that are investing in more diverse reimburse providers, so that I'm interested to see if that will actually come to fruition. I think telehealth is going to be a huge part of this conversation. Behavioral healthcare works well over telehealth for a lot of people. We've seen that during the pandemic. I use it, and I think that that's something that will be hard to go back to not using. So, we've gotten that 151-day telehealth extension. I think we'll see more on that. I'm also, something I'm watching to see is if there's going to be any movement on like licensing regulations, cross state line licensing regulations to increase the number of providers. I'm not totally sure what the appetite from regulators or lawmakers is on that, or even how that would work. If anyone here has thoughts, please reach out to me. I'd love to talk to you about that. But I've heard from a lot of providers and people in the behavioral health space that that's really necessary to make this work. And I also think we're going to need to see reimbursement rates raised, because that's another big reason that that there's a shortage of providers right now. So that's, and I'm also curious to see what is going to be proposed around quality. I've talked to some people in the space that are like, sure, access is great. We need access to mental health care, but that doesn't mean anything if it's not, if it's not high quality. Sometimes, especially with inpatient stays, it can lead to more trauma if you have poor quality behavioral health care. So that needs to be part of the conversation too. And I haven't seen a ton around that yet. So I expect that we will see that, but I'm not sure when.
Thanks, Maya. And Michelle, Inside Health Policy has that new publication, Inside Telehealth. What are the big stories that they're covering?
So I was actually building off a little bit. I want to add one thing on the mental health aspect, and then I'm going to actually build a little bit off what you had said about the state, about the licensing. So keep in mind that the Senate is set to Senate Finance is set to unveil its mental health package this summer. And the House has also been working on a mental health package. So this is one area where you could see potentially something move, where you have the House and the Senate and members of both parties saying that they're interested in this and wanting to work on this. But especially when you look at telehealth, some of the mental health issues could be seen as a little bit of a cautionary tale, because the first attempt on mental telehealth and extending that was met by some pushback from some of the stakeholders who were concerned the guardrails initially put into place were so strict that it would make it a little less useful, actually. So it's kind of getting a second look now because of that. And that kind of leads into this discussion on telehealth. Inside Telehealth is Inside Health Policy's newest venture, our newest publication. And our reporter, Kara Smith, is doing a wonderful job on it. And she just did this gigantic special report, actually, on telehealth groups split over potential interstate licensing frameworks. And this moved because you have some organizations interested in developing a national licensing infrastructure, while others are kind of focused on this idea that, look, licensing power needs to be determined by state licensing boards and state compacts. So there's this kind of push and pull there with this particular issue of, how do you figure this out? How do we work through this? And it's important to keep in mind too, that this discussion over interstate licensing compacts, how do we work with the state licensing issue, has been ongoing almost the entire time I have been reporting for Inside Health Policy. So this has been a decade-long conversation that is still in the works and kind of just brought to a head a little bit by this pandemic as people are turning to use telehealth more and more. So it's going to be an area that we have to watch and see how all of this kind of plays out.
I'll have to read that special report.
I mean, we're also looking at this idea of governance boards helping healthcare companies tackle virtual marketing, which has been an interesting space. And now there's people calling for legislation to boost telehealth access to birth control. And there's also the entire discussion or argument, if you want to broaden it and look at technology overall instead of just the telehealth aspect of electronic prior authorization. And if we're kind of moving towards some of these different areas, there's a big push for technology to impact not just telehealth, but some of these other areas that have historically been a burden, like prior authorization. And how is electronic prior authorization going to work? So there's just a few other areas to think about too in that space.
For sure. Let's turn to prescription drugs. So it used to be almost a foregone conclusion that the government was going to negotiate prescription drug prices to lower the drug prices. But I haven't heard much about government price negotiation lately. And then reviewing the president's budget, there wasn't a whole lot of discussion on new efforts to lower prescription drug prices. So what's going on with that, Michelle?
I think that is going to, I think we're going to honestly have to watch some of the reconciliation space to see some of what's going on with that, because drug price reforms had been a big part of the discussion for the now defunct Build Back Better package, and still are expected to be a potential aspect of whatever economic reconciliation package that the White House may decide to push when they come back. And we're going to have to wait and see where you can draw that middle ground between, honestly, the different wings of the Democratic Party to see who is in favor of some of this. And at the same time, you have a lot of these discussions of, okay, you have looks at negotiation, you have looks at all of these different pathways. And at the same time, though, you have to keep in mind what CMS is doing on some of this as well. For example, I think the Adelhelm conversation could have shaken up the landscape quite a bit on some of this, where there was a look at, there's, some thoughts about how the price may have played into some of these decisions, as well as looking at, how well this might have worked for certain populations. But there's just these different aspects that we're going to have to look at and take into account. And I think in some ways we're going to have to see where Congress plays out to see what the future of this is looking like. And we're just going to have to see what the White House is willing to support and where the different wings of the Democratic Party end up playing out.
Yeah, I'm not really covering Congress anymore, so I don't know a ton on that space. But something I'm watching is the CMS proposal in the Medicare Advantage Part D rule to require pharmacy benefit managers to apply all price concessions from network pharmacies to the point of sale to help patients sort of share in those savings. It doesn't seem like there's a whole lot that CMS can do on the regulatory side to control drug pricing, but this is one small part that they can do. And so I'm very curious to see what happens there, because obviously this is something that pharmacists really want to see because it helps them as well, and something that Part D sponsors and PBMs really don't want to see. And so I think that whether CMS decides to finalize that proposal or not, there will be litigation, would be my guess. And so I think that's a space to watch.
And I mean, just following on that for a second here, I was looking at the White House meetings this morning, on OMB's webpage, and it appears that PCMA has a meeting scheduled with the White House on some of these things. So, these pieces are moving, and the lobbying is ongoing in these areas.
Definitely.
So your prognostication on the direct and indirect remuneration fee inclusion and CMS, do you think they'll finalize their proposal pretty close to what was proposed, or you think the PCMA meeting at the White House is going to throw all the pieces up in the air and we're going to see something different? Or what does your crystal ball tell you?
It's hard to say. I believe, Michelle, you might know more on this. I believe CMS has proposed this policy in the past and then decided not to finalize it. So I really don't know. I think that there's enthusiasm in the Biden administration to finalize this, but I don't know what's I don't know what will happen.
Well, we're going to have to see too, because the administration is getting pressure to hurry up and finalize this from Capitol Hill as well, where a bipartisan group of senators you had Senator Brown, Shelley Moore Capito, and John Tester and James Langford all basically writing a letter to the White House and telling OMB, hurry up and finish this review. So the pressure is coming from different angles. We're just going to have to see how it all plays out.
Great. Thank you. And then, so I think that covers everything I wanted to cover. Is there anything I missed, Maya? Anything we should be watching going forward? Big stories to keep an eye out for that you're following, and that if we know anything about, you'd like to hear about, things like that?
Funny you should ask, because at the bottom of my notes here, I have a little list of other things I'm watching in case we had time. Yeah, lots of other things that I'm watching. We didn't touch too much on value-based care, but that's something that is, huge across the entire healthcare sector right now. A big conversation. Is there actually momentum on that? Is there not? So that's something that is really important to keep an eye on. As far as rules that I'm watching for, the sunset policy, a final rule on that, which that's the rule that would have eliminated HHS rules after a certain amount of time if they hadn't been reviewed. That's supposed to come out soon. A proposed rule repealing the Trump administration's conscious rule that allowed providers to refuse to perform services based on religious beliefs. I'm also really curious to see what will happen with the MSIT, TSET, breakthrough tech coverage pathways, and where things go with 340B, especially with the contract pharmacy discount restrictions. And we touched on prior authorization a little bit, but that's also something that I think is a big conversation to be had, and just with the physician payment and sequesters and calls for that to include, that fee schedule to include inflationary updates. I don't know, there's a lot going on in healthcare all the time, as everyone on this call knows. So definitely no shortage of stories.
Thanks. And then Michelle, anything that we didn't cover that you think we should be following?
I think it's going to be very interesting to watch how FDA and CMS kind of work together going forward, because you've got a couple different areas where there's been that little bit of a disconnect with both at-home and with the device coverage and the breakthrough pathways. So I think that's going to be interesting to watch how the two agencies kind of tackle this area where there might be viewed as a disconnect, and see how they kind of work together. Because, you've had officials go sit down together at public events after all of this and say, hey, we're working together. We're all on the same page. We totally understand this. So it's just going to be interesting to watch on that end. I think there's going to be a lot to watch in the CMMI space with the Innovation Center, where models are being put on hold, other models are being retooled. And we know that when Liz Fowler came in, she had said she was, doing reviews and working on a lot of new different models, which can take a little while to get up and running. So I think we're going to have to really watch that space to see how these things change going forward. I think that CMS is trying to predict where certain programs are going to continue and where they might run out. You see that in the note of the Medicare dependent hospital program yesterday with the hospital rule there, with CMS noting, hey, this program has been, renewed legislatively every time for quite some time now, but there's always a chance Congress could decide not to act and not renew this program before October 1st. And if it does not renew it, then, hey, these hospitals are going to see a cut on top of everything that we've proposed. I think we're going to have to watch some of these spaces to see how, policies from one program may affect another. When you have everybody's watching very carefully with the Medicaid redeterminations and the the effects that that might have on the insurance rate and who might lose coverage. And there are other aspects of that, like uncompensated care and dish payments and these different programs that are affected. So we're going to have to watch how that all plays together and plays out as well. And as with CMS showing that it is willing to start unwinding COVID-19 waivers before the end of the public health emergency, the big question is going to be how it makes determinations on which ones to start unwinding early, which ones to keep, and how all of that might play out, what it might look like going forward.
Thanks, Michelle. We got a question from the audience that I'll ask. There is a physician shortage problem in the US, and CMS has proposed some changes to the graduate medical education support that we all know as residency programs. And do you think CMS's proposed changes to the graduate medical education support are likely to make any difference in the physician shortage problem, specifically in mental health?
Maya, you can take that first. Go ahead.
I was going to say I'm going to defer to Michelle on this one because I didn't get a chance to look super closely into that proposal, although I would love to talk to whoever asked this question about that more in depth. But yeah, I know GME is an area that, needs some work. We're just getting the first increases in a very long time to that program. There are also a lot of residents or there are a lot of doctors who, aren't placing into residency programs that, are trained medical professionals that we just aren't using. And so I think there needs to be some updates to that. I'm not sure if this proposed solution is the right one, but I'm definitely watching.
Any additional thoughts, Michelle?
Well, I mean, we had the 1,000 new slots that Congress authorized and CMS is now still in the process of kind of implementing. That's the largest increase we've seen in more than I think 25 years. And so but then you had people who were upset about this idea of using a facility's location within a primary care or mental health professional shortage area as a primary qualifier. So we're going to have to watch to kind of see how this plays out. Does CMS stick with that policy of looking at where you are in relation to that, or does CMS decide to go another route with this? And then just yesterday, we had the proposal to, kind of let the urban and rural hospitals work on a rural training program and kind of combine that for part of their full-time equivalent caps and look at that as far as GME, have those work together. So, CMS appears to be trying to tackle this with some of its GME policies and look at it. The question is going to be how it all plays out and if this ends up honestly partially being enough. And on top of the physician shortage, though, we also have a nurse shortage, which has shown up and been exacerbated by the pandemic. So that's another workforce shortage that's going to have to be taken into account. And you also have community health centers who have been saying that they recently have had their workforces decimated as well. So these workforce shortages are kind of across the board in different areas and spreading. So there's going to have to be some discussion of what do you do to tackle the workforce on a larger scale.
Yeah, and that definitely ties it back to what we were talking about at the top of the call with payment updates maybe not feeling sufficient for a lot of different provider types because labor costs are going up so much. And I know that that's something that needs to be grappled with within the healthcare industry.
Well, thank you both. And so I think definitely the physician shortage and COVID has changed the healthcare workforce in a lot of ways. And so it's unclear how what the workforce actually looks like post-pandemic, but for sure it's changed, and more health professionals will be needed probably in all areas, including physicians and nurses. So we'll stay tuned and follow that. And Maya, any final thought for the audience before we sign off?
Thank you so much for hosting this panel and for allowing me to speak and share some thoughts. Really great to have this platform, and hopefully the forum will send out my contact information if you ever want to get in touch about any of these topics, because I would love to talk to anyone and everyone about what's going on in healthcare. And I hope to be in touch with you all.
Thanks, Maya. And Michelle, any final thought to leave our audience with?
There is obviously a lot going on in this space. What we've touched on today is probably the tip of the iceberg with some of this. And my contact information is available. I'm sure Jim will send this out. But if there is an area where you think we need to be paying attention, that things are changing and is not getting the attention it deserves, I mean, let us know. There is so much happening that it's always good to know what people are looking at. It's always good to see where people's interests are lying, as we are covering what is a very busy, very wide-ranging sector for healthcare.
For sure. Thank you. Thank you both. And so if you want to get in touch with Michelle or Maya and you don't have their contact information, shoot us a note and we'll get you in touch with them. And then also we talked a lot about Medicare's inpatient prospective payment system rule for hospitals. Our team at Applied Policy wrote a summary of that last night, and as best we could summarize a 1,700-page rule by 9 p.m. And so if you're interested in seeing that, let me know and we'll shoot you a copy of that. But thank you all for joining. We'll have another forum next month. Stay tuned for the date and subject. And thank you again, Michelle and Maya, and for all of you at Applied Policy and our audience. Thank you also. So have a great week. Thank you.